Dr. Aspa,
Yeah.
it is sharp 8 o'clock. Can we start now?
Okay. Can.
Okay. Good morning. Thank you all for finding time and visiting today's webinar. My name is Maria as the moderator of this webinar. Our topic today is sex determination in forensic anthropology, and the speaker is Dr. Aspalila Alias. Before we start, let me explain how you can talk to us during the webinar. If you have any questions during the presentation, just write them to chat, either on the Zoom or in the YouTube. Our webinar agenda, the first one is lecture from Dr. Aspalila, and the second one is question and answer session. Dr. Aspalila Alias is working at the University Science Islam Malaysia. She is a lecturer, dentist, and anatomist from November 2010 until now. From 2019 until now, she is a deputy dean in research and innovation. Dr. Aspa, you can start the lecture. Thank you.
Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asyrafil anbiya'i wa mursalin wa ala alihi wa sahbihi ajmain. Qala rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Allahumma aftah alaina hikmataka wa anshur alaina min hazaini rahmatika ya arhamar rahimin. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wa sallam. Walhamdulillahi rabbil alamin. Alhamdulillah, thanks to moderator for today, Dr. Maria Istiqomah, for accompanying me today to discuss to you all a topic, to the Dr. Arofi and the forensic odontology team in UNAI for organizing the events, the dosen-dosen, pelajar-pelajar mahasiswa UNAI dan mungkin juga pelajar USIM yang hadir pada hari ini, ladies and gentlemen. Today, maybe I will speak mixed English and also Malay to discuss about sex determination in forensic anthropology. I hope that you all okay semua. Bagaimana semua, sihat? Ya.
Alhamdulillah sehat.
Alhamdulillah. Masih di rumah ataupun di kampus?
Di rumah, Dok.
Di rumah. Kita doa semoga Allah Subhanahu Wa Taala menghapuskan COVID. Thank you very much to Yunai for invited me to give a talk about the sex determination in forensic anthropology. Sebenarnya kita mahu bincang tentang bagaimana kita mengetahui tulang ini tulang siapa, male ataupun female. So in the forensic case, to determine the causes of death, that involves many parts of team in the forensic anthropology. So we have forensic toxicology, the team that deal with the blood and urine and so on, to know the cause of death. We also have a forensic entomology that deal with insects. With the insects, we know the cause, the time of death. And we also have a team of forensic botany that study the soil. Tanah ni, daripada tanah ni boleh diketahui bila kematian mayat itu terjadi. Dan we have a team of forensic odontology that know about the identification from the teeth. And we also have a forensic pathology, the main person that involved in postmortem. So the person died, we know what the causes of death of the person. So forensic pathology with deal with the postmortem examination. When the patient die, the person that do a postmortem we call forensic pathology. So sometimes we found the dead person without soft tissue. In a few weeks, the soft tissue will decompose, and what we have is only bone. So when the apa ni, bila mayat sudah reput, yang hanya tinggal adalah tulang. Bila dah tinggal tulang, is very difficult to determine who is the mayat is belongs to. So the forensic anthropology will take part to examine untuk periksa tulang-tulang ini kepunyaan siapa. Kerana bila manusia itu mati, kita perlu ada haknya. Waris mesti tahu siapa yang mati, adakah anaknya ataupun keluarganya. Kerana di dalam Islam kita ada hak-hak sebagai Muslim untuk dikapankan, dimandikan dan dikebumikan. So as a forensic anthropology, they will deal with the bone. So how to know the bone is belongs to who? So when we talk about forensic anthropology, is defined as the field of study which focus on examination of human bone systematically in order to get the identification of the remains in medical legal case. So kesimpulannya forensic anthropology adalah satu bidang yang memeriksa tulang secara sistematik. Kita cek setiap tulang ini, kita ada 206 tulang. Dan setiap tulang ini memberikan clue bahawa tulang ini kepunyaan siapa. Oleh itu, forensic anthropology akan mengkaji setiap tulang yang ada, iaitu 206 tulang yang dijumpai untuk mengetahui apakah agak-agak tulang ini dipunyakan oleh siapa. So as we know, our body is very complicated. It's a very complicated that involve we have a skin. Below the skin we have a soft tissue, superficial fascia, deep fascia, and then we have muscle. When we have muscle, before we go to the bone, we have muscle. So the bone is the muscle we attach to the bone. So our activity, like we eat and so on, or we move, or our job can influence the shape of our bone. So how about this one? So actually, our bone is 206 bones. We consist of the exoskeleton bones at the center, and we also that consists of the skull. We have 28 bones in the skulls. We consist of also the crania and also the mandible. We also have a cervical bone. Cervical bone, we have 7 cervical bone, and then continuously we have a 12 thoracic bone. We also have ribs, ribs, 12 ribs at the center. After the thoracic, we have a lumbar, 5 lumbar, and then we have a sacral bone, and lastly we have a coccyx. This is we call exoskeleton that connect located at the center of our body. We also have a sacral bone, sacral bone. So we also have a appendicular bone at that attached to the axial bone that we have the scapula. The scapula connect the central or axial bone to the upper limb. In the upper limb, we have a long bone, which is a humerus, and then we have ulna at the medial and also radius at the lateral. We also have a carpal bone. Carpal bone, 8 carpal bone. Then we have 5 metacarpal bone, and we have 14 phalanges. And then we have also bone, the big or hardest bone in our body is a femur, and the femur connect our central with the pelvic bone. And we also have a bone that we call tibia at the medial side, and also fibula bone. And we also have a tarsal bone, 8 tarsal bone and 5 metatarsal and 14 phalanges. So all the bones is 206 bones in our body, and each of us have different shape or different structure of bones that make us different. So in study of bone, each bone study individually. So we susun bone mengikut anatomical position. So we count it, and we examine every bone, and we choose whether this is probably female or male, is a Chinese, Malay, or Indian, or it is what age of the person. So in anthropology is a study of your human skeletal remains to determine sex, age, race, stature, and time of death in effort to study an individual. Untuk kita mengkaji tulang mayat yang kita jumpa, sebenarnya tulang ini memberi sedikit clue bahawa tulang ini adalah lelaki atau perempuan, umurnya, bangsanya, ketinggiannya, dan tarikh kematiannya. So dia termasuk juga topik of facial reconstruction and age progression. So anthropo is a Greek Greek name for human male. Logos means study of. So we need to study of the bone to know what the characteristic or identification of this bone. So when we study the bone, actually we want to know the bone is identify of apa. Adakah umur human skeletal remains yang kita jumpa tu umurnya tua, muda, lelaki ataupun wanita, race mungkin Caucasian, Mongoloid, ataupun race, stature, ketinggiannya, and it's based on biological differences between sexes and also races. And as we know that males are generally taller and more robust, but sometimes we see the male is shorter than female. So this is a variation that we see during we examine the bone, as well as differences due to the ancestry. Sometimes the shape of the male in Malaysia is same with the female in Europe sometimes. So, however, it is imprecise because so much human variation exists, and because of racial differences tend to homogenize as a population interbreed. That's why kita perlu ada database untuk setiap populasi. Di Indonesia punya populasi, kita perlu ada bone untuk orang Indonesia untuk kita kaji di Malaysia dan di negara-negara lain juga. Kita tidak boleh mengambil data ataupun equation daripada populasi lain untuk digunakan. Mungkin akan berubah sedikit. So still differences do exist, and the more features you survey, the more precise your conclusion would be. So in anthropology, when we found the bone, actually we need to investigate either the bone is a human or animal. We can see here, this is a two bone. Where is a bone of human? This one or this one? Up or below? Hello? So mana tulang manusia? Di atas atau di bawah? Siapa boleh jawab?
Atas.
Atas, iya. Atas ini adalah tulang manusia, and di bawah ini adalah tulang cow. So bentuknya kita dah jumpa, katanya kita jumpa mayat tulang. Bila cek-cek bukan manusia, rupanya tulang lembu, lembu mati di tengah hutan. Kita ingatkan manusia, bila cek tulang lembu. So we exclude the remains as a human. So bila kita jumpa tulang, pertama kali kita kena bezakan antara itu tulang kanak-kanak ke tulang kucing ke, kita kena bezakan antara human bone and also animal bones. The structure, the histological structure also different. So how many individuals? We can see this one. How many individuals? So we need to calculate how many skull. If there is a 10 skull, maybe 10%. Sometimes so we calculate 10 skull, but the humerus have 11. Terlebih pula. Cek-cek, oh lagi satu tulang itu bukan manusia, tulang lembu. So we need to examine systematically untuk memastikan bahawa tiada data yang tertinggal. So bila kita melihat kepada tulang ini, kita perlu ketahui seks dia, female ataupun male, bangsanya, ketinggiannya, adakah ada osteoporosis pada tulang ataupun berlaku trauma. Bila berlaku trauma, katakan kena tembak, so we can see the traumatized bone in the skull, for example. So we need to know the identification of sex, age, race, stature, and also any pathology, condition or trauma in the bone. Okay, so we can see this one whether this is a female or male. So after this, I will teach you thoroughly about how to know, because today the topic is a sex determination. So we focus for sex determination. Bagaimana ingin mengetahui tulang ini dipunyai oleh lelaki ataupun perempuan. Okay. So apa beza sex and gender? When we talk about sex in anthropology, kita tak sebut gender sebab gender ni berbeza dengan sex. The sex is a physical anatomical difference between male and female. And often based on the gamete or gene. So kalau kita perempuan, kita akan XX kan. Kalau lelaki, XY. Tapi gender is a social construct. Specify the socially and culturally prescribed role men and women are to follow. Okay, influenced by individual biological sex. So ini adalah lelaki. Lelaki yang berpura-pura menjadi perempuan. So dia mengaku dia adalah wanita. So the gender is female, but actually the sex is a male. So this is a female. Sex and gender is a female, and this is sex and gender as a male, but this is mixed up. The sex is a female, but the gender, the sex is a male, but the gender is a he claimed that he is a female. Actually, he is a male. So of course, how to know this is a male or female? Firstly, we need to know the size. Usually, you can see the face. You can see that the male usually larger and more muscle than females, because we have for the male they have a testosterone. The testosterone will stimulate the muscles and also to the bone compared to the female that has estrogen. So architecture, female pelvis designed to bear children. So bentuk tulang pelvis atau tulang punggul wanita adalah memang dijadikan oleh Allah bentuk untuk senang untuk melahirkan anak. So the problem is we can see that the problem is the population variation. We can see that this is Europe female and ASEAN female. So we can see that the bone is look like the same. That's why we want to have our own ASEAN database to know whether this is a male or female to make a good conclusion. So actually to determine the sex is very difficult to sangat susah and not very accurate when we determine person less than puberty kanak-kanak. Sebab kanak-kanak ini masih belum dia punya hormon masih belum berkembang dengan baik, menyebabkan kanak-kanak lelaki dan kanak-kanak perempuan tulangnya tidak dapat dibezakan. Because the sex differences do not become pronounced until their puberty, sampai dia datang head atau umur matang. So it's very difficult when we find a bone of a children, immature skeletons. So when we see the bone, actually we need to identify whether the bone is belongs to male or female, bangsanya, umurnya dan juga ketinggiannya. Kita juga boleh mengkaji tentang tetapi kebanyakan yang ini sudah tiada di antropologi kerana scar, tattoo marks, any abnormal itu kita tak dapat detect dekat tulang. Tapi kita boleh compare antemortem and postmortem comparison trait. Kalau dia ada buat x-ray sebelum meninggal, kita boleh tengok x-ray. Kalau ada x-ray tulang lah. So kita boleh compare. So when we talk about sex accuracy is easy. You just focus these two bones, which is a skull, tulang tengkorak dan juga pelvis. Bila kita jumpa dua tulang ini, tulang tengkorak dan tulang pelvis, sebenarnya 90 hingga 100% anggapan kita adalah tepat. Tepat. Hello. And then untuk andai kata kita tidak mempunyai tulang tengkorak, kita hanya berjumpa pelvis sahaja, tulang pelvis, kita hanya 90 hingga 95% accuracy. Tetapi jika tulang tengkorak saja, kita 80 hingga 90% accuracy. Maknanya kita bila jumpa tengkorak ni, bila kita check, kita tahu this is a male. So 90% confirm is a male or female. Ataupun long bone, kurang daripada 80%. Kita jumpa tulang humerus ke apa, kita boleh teka dia ni male ataupun female. So we will check three of these bones, the skull, the hip bone and also the femur, okay? Now, but the sexual dimorphism is depend on the endocrine or hormone system. As I said that the male will produce testosterone and the testosterone will stimulate the muscle and also the bone, menyebabkan tulang lelaki ataupun muscle lelaki lebih besar daripada wanita dan menyebabkan tulang lelaki akan lagi besar, bigger and robust. And secondary physical and sexual characteristic, and it is a difference intrapopulation and between interpopulation. Maknanya antara dalam populasi itu dan populasi, contohnya di Malaysia dan Indonesia mungkin berbeza bentuk tulangnya. Mungkin kita sama kerana kita serumpun. Mungkin bila kita compare dengan Europe dan negara yang agak jauh, dia berbeza struktur tulangnya. Also affected by psychological, emotional behavior changes. Mungkin tangan seorang dentist, mungkin kita guna banyak tangan semasa treatment, mungkin tangan kita tulangnya lain compare to pekerjaan yang tidak memerlukan tangan. Begitu juga aktiviti yang lasak, contohnya lelaki yang sasa, mungkin tulangnya lagi kuat dan lagi kasar dan sebagainya. So different base size and functionality, and female more smaller and gracile, while the male more larger and rough. Okay. So as I said, how to know, actually we use 3 method to know whether this is a male or female. First is we do the morphological features. Maknanya kita tengok tulang tu, tengok ciri-cirinya, kita boleh tahu. Kedua, osteometric, kita ukur. Kalau tulang ni panjang macam ni, kita kata female. Kalau tulang ni panjang macam ni, kita katakan male. And the latest is a geometric morphometric analysis ni, analisis yang kita buat untuk mengetahui tulang ni kepunyaan siapa melalui bentuk shape. So sex differences are also population specific, dependent on the race or ancestry. Okay. So what is the bone is? This is a pelvic. Alright. So pelvic ini tulang apa? Tulang punggung. Tulang ini adalah untuk melahirkan kawasan di mana childbirth, baby dilahirkan melalui sinilah. So seorang wanita perlu mempunyai struktur tulang yang agak besar dan bentuknya untuk melahirkan seorang baby lah. So dia terdiri daripada 4 bone. We have ilium bone, ischium bone, and also pubic bone. And we also have a sacral bone. So bentuk tulang bagi tulang punggung ini perlulah mempunyai bentuk wanita untuk menyatakan dia wanita. Sebab bila kita jumpa tulang pelvis, kita dapat tahu bahawa 90% adalah tepat itu adalah wanita atau lelaki. As we know that the pelvis of woman is wide and circular, while the pelvis of a man is narrow and heart shaped. So kita tengok tulang tu, tengok wanita itu dia punya tulangnya circular, pelvic inlet dia circular dan besar, by the man narrow and heart shape, berbentuk heart shape. And the two angle, the subpubic angle and the sciatic notch is different. The subpubic angle and sciatic notch are wide. In men, the subpubic angle and notch are narrow. Okay, we can see that this is where is the male? We can see that the inlet is a heart shape, heart shape, bentuk love. We can see this one. But the female is more circular. And then we go to the subpubic angle. Subpubic angle for female is wider. Wider subpubic angle of the male is less than 90. And then we have a sciatic notch. Sciatic notch kat sini tak nampak. And then we have the female broad pelvic inlets. So we can see that where is male, where is female? Di mana? Ini male or female? Ini male, ini female. We can see that the subpubic angle is wider compared to the male. The male is narrow, narrow. So we can see the inlet is wide compared to the male. Is narrow. So and the ilium is a flare, shallow flare out, while the male is a deep or funnel shape. Dia ke sini, kecil ke dalam. So when we see this one, we know this is a male, this is a female. So we can see juga the pelvic inlet. Tengok ni heart shape. So we can see this is a heart shape of the male. So we can say this is a male and this is a round shape or circular shape of the inlet of female. So kita kata this is a female. So we can see the space of middle of the pelvic bone is larger in a woman to facilitate the birthing untuk melahirkan anak lah. Okay, so we can see the subpubic angle. Mana female, mana male? Ni male ke female? Hello?
Female.
This is a female, while this is a male. We can see the subpubic angle of the female is wider, while the male is not less than 90. And the shape of the length of the is wider than the male. This is the summarize of that what we talking about. So we also, so where is a female? You can see thoroughly this is a female, the larger subpubic angle. We can see the the male is less than the 90 degree. So this is the things that we know see in the male in the pelvis, whether this is a female or male. So this is we call it scatic notch. We can see the scatic notch of the male is small and deep compared to the scatic notch of the female is wider and shallow. So we can put our hand as a guideline to know this is a male or female. We can see that when put our finger, jari itu, kita tengok the female, the male is like this, very the angle is shallow compared to female, more wider. So the female subpubic is greater than 90, while male is less than 90. And the scatic notch of female more than 68%, by male is less than 60%. And the sacrum, see the sacrum, sacrum of in woman is straight, compared to the male. So this is a sacrum, tulang sacrum. Is a large triangular bone at the base of the spine and at the upper and part of the pelvic cavity. And so you can see that the sacrum of the male is shorter and wider. Tengok dia lagi lebar dan dia lagi pendek compared to the male is longer and also kurang wide. You can see that in male the sacrum is straighter and the female there is a curve in female. So this is the summary of the female and also male pelvic bone. We can see the degree of subpubic angle is more than 90 for female, while the male is less than 90. And the sacrum tilted back for male, female. This is tilted forward for male, so to give senang untuk birds. And then we have flare for the female. Dia punya ilium dia lebar compared to male. And then we have this is greater scatic notch. This person Walker they summarize that if the shape of the sciatic notch is number 1 like this, they compare. So this is a confirmed female. But going to the 5 is a male, is a more male. So ni tengah-tengah lah, either male atau female. So they do a research and they compare. So you can also see the sciatic pubic ramus. For male is a big, wide and blunt, while the female is narrow and sharp. For of the pelvic bone, pubic. Okay, and then we can see the pubic body for male is a triangular, for female is a rectangular atau square, 4 segi. Yang ni 3 segi untuk male. So mana female, mana male? A ke B? Mana female? Hello? Where is female? Mana wanita?
B.
B, yes. So the B is a female because the sciatic notch is wider compared to the A, is a male. So how about this? Male or female? Is a rectangular shape.
Female.
Yeah, this is a female. This is a rectangular shape. Kalau male is a triangular shape. So this one? This one? Male or female?
Male.
Male or female?
Male.
Male or female? This look like a male. Okay. So this is the apa ni, the guideline that we will compare. Maybe number 3 tadi, male or female. But we will see other parts. Which more? For this one, this is a male, this is a female. So this is the guideline that we need to compare. In my eyes is a female, maybe your eye is a male. So the researcher already do the research, and then this is the guideline that we can see lah, whether this is a male, more towards to male or female. So just some apa ni, macam mana nak hilangkan ni. Okay, so this is so compared, where is male, where is female. Number 1, the angle, less or more? Then more. Okay. The sacrum, forward or backward? Backward. The pelvic outlet, small or large? Compare this one.
Large.
So the ilias, small or spread?
Small.
Compare this one. Ni macam small, ni macam spread kan. Female or male?
One female.
Two? Male. Okay. Okay, good. Okay, I can stop here. Alright. Okay, next is a skull. So what can you see a skull? How to know there is a male or female? So you can see the supraorbital ridge, the glabella, supraorbital margin, external occipital protuberance or nuchal crest, muscat process, and mandible. So we see the 1, 2, 3, 4, 5, 6 things before we know this is a male or female. So this is a nuchal line, and this is nuchal line. So the umbilical also the category this shape, 1 is female, more to 5 is a male. Sometimes we see a difference or variation of shape. So we can see whether more to male or more to female. All right. So when we see the nuchal line here, so is the nuchal line is like this is more to male, and nuchal line like this is more to female. And then we see the mastoid. We put the line from the zygomatic arch, we put the line, then we draw. So if the number 1 is a female and more towards to 5 is a male. Begitu juga dengan supraorbital margin. Supraorbital margin, if the shape is like this, is a female, sharp margin is a female, while more blunt is a male. And the supraorbital or glabella, kita tengok atas ni macam mana. Kalau tertonjol begini adalah male, while this one agak smooth adalah female. Though we see the mantle of eminence of mandible, that the shape like this, not less prominent is a female, but more prominent is a male. So this is a skull. The 5 things that we see. We see this one. This is the mandible, and we can see the mustard process, and then we see the zygomatic arch, and then we see the glabella and supraorbital orbital margin. And this is a nuchal line. So this is a general appearance of the skull. First kita tengok tulang tu kasar ke tak. Kita rasa kalau lelaki dia kasar tulangnya, kalau wanita dia smooth saja. And then we see the supraorbital ridge, orbits, glabella, zygomatic arches, mustard processes, external occipital protuberance, mandible, and pellets. Okay, I will show you one by one. So this is where is a female and male. So we can see that the male is robust, robust bone compared to the female, as we know that this is the attachment of the muscles in the face and the muscle of mastication. So the male is more robust. Bila kita pegang dia kasar, dia more robust, besar, dan dia tak smooth. So the female is more smooth. And then we can see that the shape of mandible is a square, and then we can see the angle of the mandibles is everted compared to the female, more inverted. So the shape of the female is round, and the shape of the is square. And then we can see this one, glabella, is prominent compared this one. Female is smooth. And you can see supraorbital ridge is very prominent in male, but the female supraorbital ridge is slightly. So we can see the broad shape of the male more prominent compared to the female, smooth and more vertical frontal bone. We can see the female, the mastoid process is larger compared to the female, is a small mustard process. So this is the differences between male and female. And we can see the supraorbital ridge of the male is prominent compared to female, is sharper. Begitu juga dengan frontal female skull is smaller, and the frontal and parietal bossing in male is more, and the sloping of male is larger. You can see the sloping of male is larger than the female, more straight. The glabella is developed, but the glabella of the male is more prominent, and this one is sharp. Is sharp for male. Female is more blunt for male. So we can see the zygomatic arch. The males is more larger compared to female is a narrow. So this is a male zygomatic arch, and this is the female. So you can see we compare, this is a male, this is a female zygomatic arch. And you also see the mastoid is very prominent in male, but this is less prominent in male. You also see the square shape of the mandible here. The slope of the of the frontal bone of the male, and quite straight of the frontal of the female, and the more gracile and with this more robust and larger. And the muscle process, as I said, the muscle process of the male is more larger compared to the female. And this is a nuchal line. External occipital protuberance is more prominent in male compared to the female. And then, yeah, this is the summarize. We can see the nuchal crest, and also the mustard process of the male and female. So this is a male mandible, while this is a female mandible. That you can see that the shape of the mandible is square shape compared to the female is a chin is a round shape, and then you can see the angle of mandible is inverted, and it's more inverted, and you can see the rough of the upper bone of the main mandible compared to the female. So again, this is a mandible. This is a male, and also this is a female mandible. So we can see in the male palate is wider and broad compared to female, and you can see that the male also more rough of the bone compared to female, more smooth. And then we can see compare this is a male or female. We can see that this is a we can see chin. So the chin is round or square. This one, round or square?
Square.
Square. This is a square. Compare this one more round. And how about this one? Mustard process. Mustard process large or small? Compare this one. So this is more large.
Large.
And we compare, this is more robust compared to this one. And we can see the this one prominent supraorbital ridge or glabella, and then we can see the orbital margin sharp and you agak blunt. So this is most probably male or female?
Male.
Male.
Yeah, this is a female. So again, how to know this is a male or female? Chin, round or not?
Round.
Round. The mustard process?
Smaller.
Smaller. Occipital protuberance kita tak nampak. How about the forehead pun tak nampak. The muscles line not too prominent. Okay. So most probably this is a male or female? This is a female. Okay. So this is because some muscle attachment at the our bone, and also muscle of mastication, and also facial expression. So we also use other bone like humerus. We use the equation from others population, then kita ukur lah. So most probably a female, for contohnya 305.9 mm, while it is a male 339. But this equation they take from the Caucasian or from the Europe. So it must maybe difference for us because kita lagi rendah daripada orang. Mungkin lelaki kita sama dengan perempuan di sana. So that's why we need to have our own database to know where is a female or male. We also measure the bone to know other bone to know this is a male or female using the database that provided. So this is a femur conda. So the femur intercondylar notch more kita tengok apa ni where is a male and female. You can see the line, the linea alba is prominent in the male compared to the female. So we compare. So we also study the sternum to know this is other bones that can help us whether this is a male and female to finally conclude that this bone is belongs to male and female. But first thing we need to study these two bone, the mandible, the skull, and also the apa tadi pelvis bone. Okay, and then we see other bone. If these two bones is confirmed, so I think no need to see other bone. If these two bones is we query whether this is a female or male, so we need to examine other bones. Actually, we need to examine all the bones to confirm it. But sometimes we cannot find the bone. So we will just use whatever bone that we find. So they also use a few other bones like scapula and also clavicle. So where is a female, where is male? So we can see that apa ni sharp supra margin rim. Kita boleh tengok daripada situ, kita bawa tengkorak tu ke situ, kita akan tengok the female supraorbital margin is sharp compared to male. Male is rounded. So the broadridge of the male is large and pronounced compared to female is round. Where is a male? Where is female? This is a
Male.
This is a female. All right. You can see very big apa nama mastoid compared to the female, and the nuchal line here or occipital protuberance is very prominent compared to the female. So we can see where is a male, where is a female. This is a
Male.
This is a female. This is more square and this is more rounded. You can see the angle of the mandible here. See, this is inverted compared to the angle of mandible here is inverted. Okay. So this is a male or female? Male or female?
Female.
Male or female?
Female.
Oh, tengok apa? Tengok ni, kan? Straight ke slope? It's like straight. So this is a female. The zygomatic arch sampai sini je, dia tak continuous ke sini. And then we can see the mastoid. Mastoid is not well developed compared to male. So this is a female. And then we can see the glabella is not prominent. So this is a female. You can see the very smooth bone compared to male. So this is a female. So this one, mana male, mana female? Nampak ni? Prominent apa? Prominent broadridge. So this is a male. So ongoing research is we do a geometric morphometric analysis in a few bones now. We do research. We do ended cervical, thoracic bone. Two of my master students do cervical bone. One of my PhD student do thoracic. and my friends do the pelvis, and this is my PhD also. This is my friends did seats, and the lumbar also one of the PhD. So one of the bone is one PhD student lah, to study the bone. So this is the one that I did. Alhamdulillah, we managed to won the competition. Okay, this with the geometric morphometric analysis. Because our eyes sometimes lie. Sometimes I said male, you said female. So we use a data analysis with our database that we study. We found that this we do the CT scan and we compare with our data. We found that this mandible is belongs to male, Indian, and is around 40 to 60 years old. So we won awards from this competition. We also share a conference, seminar and workshop about this course. So I went to Barcelona for study the geometric morphometric analysis of 2 times. And this is just promote my books, a few books about the fix, the science and also Islamic. So kita pergi juga ke Poland untuk study yang lagi mendalam tulang-tulang yang serpihan. So tulang-tulang serpihan ni macam mana kita nak tahu seks je. It's more difficult. So we go to kita nak tengok tulang serpihan yang terbakar. Bagaimana kita nak tahu ini tulang ini kepunyaan siapa. So we went to the Poland to study the bone, beribu bone, serpihan-serpihan dibahagikan kepada 10 mm, 5 mm and 2 mm, dan kita study setiap bone. And we compare the bone is what ribs and so on. This is my friends from US. So we do the analysis, and yeah, we found this have two remains, human remains. Okay, yeah, this is di mana ya, Bromo? Okay, this is I just visit you all last few months and last year. And then this is Ailangga, and I end with the hadis, man arada dunya fa'alaihi bil ilmi wa man arada al-akhirah fa'alaihi bil ilmi wa man arada huma fa'alaihi bil ilmi. Barang siapa menghendaki kehidupan dunia maka wajib baginya memiliki ilmu, dan barang siapa menghendaki kehidupan akhirat maka wajib baginya memiliki ilmu, dan barang siapa menghendaki keduanya maka wajib baginya memiliki ilmu. Thank you. Assalamualaikum. Any questions?
Dr. Aspa, thank you very much. We already have a few questions. The first one is from Dr. Anis Irma. For rapid detection of sex in the corpse, which are the priority region for the examination? Thank you.
Sorry, what are the questions?
For rapid detection of sex in the corpse, which are the priority region for the examination? Thank you.
For when we see the corpse or human remains, first we need to put the bones in anatomical position. All the bones we collect, and we divide, we examine one by one of the bone, whether the bone is a human or is a human or is a animal. Whether this bone is how many bones, how many people the bones is belong, and then we separate it. If we know, this bone is belongs for this A person, or this bone is belongs to B person, or this is maybe 2%. Okay, so we put on chair or on table. So we examine one by one, from the skull, the skull, the axial bone, and also the appendicular bone, the upper limb and lower limb. So we examine one by one, and then we tick, this is probably male or female. We release all the bone, then we tick, of the bone is belong. But for sex, we focus on the head, the skull, and also the pelvic bone. If the skull and the pelvic bone confirm this is a female, so we confirm that this is a female. So like that lah. So anything that we find, we is a proof. So kita kena examine. Even though we only find the humerus, so we need to examine the humerus too. I hope that will answer the question.
Okay, thank you very much. And the next question is, this is the topic of mixed marriage. So mixed marriage now between races, does that have any significance in determining sex by bones? And will the individual show more features in one race? For example, a European Asian mixed race, which guidance should we follow, the European ones or Asian ones? Or it is only matter for age estimation more than sex determination? Thank you.
Okay, in anthropology that we don't have other clue. We find only bone, for example. So what we do is first we need to know 4 things. First is sex, second is age, third is race, fourth is time of death. Stature, ketinggian. Firstly, we see the sex, first sex. So whether this is a female or male. And then actually we know the person yang hilang biasanya okay, seorang person hilang dalam satu kawasan. Tiba-tiba ada orang jumpa tulang tu. So kita nak confirmkan tulang tu betul tak orang yang hilang tu. So first kali okay, katakan kita compare orang ni female. So kita check betul tak? Betul ke tulang tu tulang orang tu atau rupanya tulang harimau? Alamak, kalau tulang harimau yang kita jumpa kita exclude. Lepas tu kita check sex. Katakan tulang manusia confirm ada seorang. Seorang tulang kepunyaan seorang tu. So kita check sex. Check sex dia, oh this is female. Okay, yang hilang itu pun female. Okay. And then we check apa ni, age. We check age. Check gigi dia, check tulang dia, tulang clavicle dia, tulang beberapa tulang untuk check age. First kali kalau age, gigi. Kita akan tengok gigi yang paling accurate. Kalau tak, lepas tu kita akan panggil forensic odontology untuk tengok untuk age. Kalau kita confirm oh ini anggaran umur 40 hingga 60. Okey, yang hilang tu pun 40 hingga 60. Okey, kita will very narrow down. Lepas tu race. Race tu yang agak jauh race tu kita tengok kat skull. Skull tu boleh tengok boleh tahu apa race muka either mongoloid, caucasoid ataupun Caucasoid, mongoloid, lagi satu negroid kan. Shape daripada tu kita boleh tahu. So kalau apa Melayu orang Asia ni mau kepada mongoloid shape. Rupanya yang meninggal itu adalah orang Indonesia. So the shape must be mongoloid. So then we stature. So kita ukur tulang dia, okey kepan macam ini tulangnya, ukur macam ini. Ketinggiannya 175 meter. Okey, sama. So inilah orangnya yang kita cari. Macam itulah. I hope answer the questions.
Okay, thank you very much, Dr. Aspa. The next question is, in a disaster case, how can you determine that the fragmented bones are coming from the same individual? Thank you.
The fragmented bone is very difficult actually to know whether this belongs to who, because it's a fragmented. What happened in Malaysia, there's a few case that kena bom, orang tu kena bom. So dia orang kutip beribu ada kes kematian someone ni dibunuh dan dibom untuk menghilangkan bukti kan. So biasalah akan jumpa juga tulang. So apa terjadi, dia orang compile the forensic team will compile the tulang dan beribu tulang tu dia examine in the postmortem mortuary. Lepas tu bila check actually cannot, because bila dah kena bom, if we can extract the DNA, kalau DNA tu ada, biasanya DNA is a protein. Dia dalam suhu berapa je kita boleh tarik. If the bone we can extract the DNA from the bone, kita akan kurang bukti. Tapi shape of the bone yang dah tu sebenarnya susah untuk, that's why kita kena check mana yang serpihan yang kita boleh tengok. Actually quite difficult. The more disrupt of the bone, kalau dapat sebiji bone tu okay. Kalau bone yang dah dipecah-pecah, it's more difficult. But we can collect and kita akan kumpul, kita akan study satu persatu untuk mengetahui. That's why kadang-kadang forensic case memakan masa berbulan-bulan untuk mengetahui keputusannya. Kadang-kadang terpaksa gali balik mayat tu untuk tahu tulang tu macam mana. Okay. Hope answer
Okay,
the
Dr.
questions.
Asma. We still have 5 minutes left. The next question is, okay, if there is any case, for example, in a school, there are some signs indicate that it is male, but there are also some signs that it is female, then how to determine it is male or female? Thank you.
So as I said, I will teach you how to compare male and female kan. First we see the very important bone is pelvic bone, and then we see the skull. After that, we see other bones for the examination. Usually, other bones also give a clue. It's a kalau it's a rough, very rough, we can see that it's a male or female. Sometimes we can, if the bone, we can also extract the bone. We can go to histology, and we see in the histology the bone structure, the bone structure of the male and female difference. So if morphological and osteometric cannot be determined either male and female, we can bring it to the lab to see the histology or cross section of the bone, and also the DNA of the bone. Kalau boleh extract, if the protein is okay. Kalau tak boleh juga, kita nak buat macam mana kan? This is the last. But we try. And we compare. This method okay, this method kata perempuan, this method kata perempuan, this method kata lelaki. So which is the best? Kalau mungkin morphology ni ada bias sikit, kita panggil juga pakar lain yang memang ada experience. Macam mana ni tu lelaki perempuan? Oh, my experience, this is a male. So kita panggil lagi. That's why kadang-kadang kita terpaksa panggil expert daripada luar yang berpengalaman banyak untuk determine this is belongs to what. That's why kalau tak pandai, tanya orang yang lagi pandai kan, kita study. Especially kalau yang mati itu adalah orang yang wanted ataupun case yang high profile. So everybody in Malaysia or Indonesia want to know kan who. So memang kena investigate betul-betul. Tapi orang yang biasa-biasa kan, kalau mati pun orang tak kisah, kadang-kadang tutup case kan kadang-kadang. That's all I can say.
Okay. The next question, Dr. Aspa. This one is about transgender who have done hormonal surgery. In this case, will it affect the determination of sex? And how about if we don't know their previous medical data? Thank you very much.
Actually, transgender, okay, you can inject the hormone, you can do operation, you can remove your penis, and then you can do the surgery yang you put the artificial vagina and so on. But remember that you cannot replace the uterus. The only female can pregnant, only female have a uterus. So even though you do a transgender and whatever, please do X-ray. I can confirm you are male or female. So in whatever you try to manipulate, you are male or female, you cannot lie medical and also awal lah, tak boleh lah. Memang kita tak boleh ubah, itulah. You cannot transplant your uterus and put inside. Okay, that's all.
Okay. Thank you very much, Dr. Aspa. Looks like we answered all your questions, the participant. And Dr. Aspa, is there anything else you would like to mention?
No, thank you very much to the Unite who invited me for give a talk, especially to apa ROV and also apa forensic odontology team. Thank you very much.
Great. Thank you very much, Dr. Aspa. Terima kasih banyak. And thank you for participating in today's webinar. We hope to see you again next time. Thank you very much.
Alright.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you, Dr. Aswa.
Prof.
Terima kasih.
Ingatkan tiada.
Oh, ada. Saya jam 7.45 sudah ada, tapi masih kosong. Saya ada dari awal. Oh, luar biasa, luar biasa, luar biasa.
Prof, thank you. Jumpa
luar
lagi.
biasa, jumpa lagi. Saya ikut terus dari tadi sampai finish.
Nah, I
luar
thought you
biasa.
don't know.
Oh no, I know. Maybe I am the first, okay, but nobody. host is not yet ready when I put it.
Masya Allah.
Yeah,
Masya
so
Allah.
I.
Thank you, Prof.
Yeah, thank you for your lecture, nice lecture, good lecture today. Thank you.
Thank you, Prof. Bye-bye.
Bye-bye.
Bye. Take care.
Yes, thank you. Bye-bye.
Bye.
God bless.
Oke, untuk peserta pada webinar kali ini mohon diharapkan untuk live group karena sudah akan ada ini webinar yang selanjutnya. Terima kasih banyak.
Terima kasih, dokter.
Terima kasih, Dr. Arafi, Dr. Maria Istiqomah, Dr. Nana semua.
Terima kasih semuanya.
Matur nuwun Prof Mika. Sampun hadir.
Assalamualaikum, Dr. Anis.
Waalaikumsalam, Dr. Adia Stuti, matur nuwun. Prof Safitri, matur nuwun bergabung. Ini moderatornya teman-teman IPM ya, Dok?
Ya, dokter, dari saya.
Alhamdulillah.
Dr. Anis, ya, mohon tunggu sebentar ya, dok. Kami sedang cek masih.
Cek slide.
Iya, dok.
Oke. Jadi sebenarnya untuk kegiatan SOS kita hari ini pesertanya ingin banyak yang mau gabung. Cuma karena keterbatasan room Zoom kita jadi
Kuotanya ya.
Room Zoom-nya terbatas. Dok hanya 300. Jadi sebagian kalau lebih kita arahkan ke link YouTube kita. Karena materi hari ini sangat-sangat menarik sebenarnya, mulai dari sesi awal sampai dengan sesi 3 sesi kita hari ini, Dok.
Oh, yang ketiga apa tadi kemarin saya lihat leafletnya kok hanya 2 ya?
Yang di leaflet hanya 2 karena yang masuk jadwalnya dies natalis, Dok.
Oh, gitu.
Jadi yang masuk agenda dies memang hanya 2. Yang pertama tadi forensik, kemudian yang kedua teman-teman IPM ini.
Good morning, Dr. Aji.
Oh, ini sudah ada.
Nice to meet you. Hi.
Still mute, Dr. Aji. You still mute.
Hello. Very pleased to meet you again, Professor.
Hi.
Thank you for this lecture, Dr. Aji.
Oh, thank you very much for inviting me. I'm not sure whether I will finish it on time or not, but I will try.
Morning, Dr. Aji. How are you?
Morning.
I'm very fine. Thank you very much, Professor Savitri. How are you? Long time no see.
Sebentar saya lift dulu.
Sudah selesai dia.
Sudah, Fit. Bentar aku tak.
So we will start on time, right? At 9:25, right?
Insya
Selamat siang. Ini bisa saya mulai ya, Dokter Rere dari IT Team ya. Oke, jadi kita akan masuk sesi kedua untuk SOS Stovit Online Series pada hari ini. Sesi kedua ini dengan pembicara dari Dr. Ajirafu. Jadi saya akan menggunakan bahasa Inggris ya, mohon izin. Jadi good morning ladies and gentlemen and honorable speakers and colleagues and students. Welcome to the second session of Stovit Online Series. Thank you for joining us for today's webinar. My name is Nurina Febrianti Aintias and I will be your moderator in this session entitled Oral Cancer and Oral Potentially Malignant Disorder, Current Practice and Future Strategy. And we also will have question and answer session after the lecture. If you have any questions, put in the chat box.
Coba diklik kanan muncul ada ini enggak?
Halo.
Coba diklik kanan gitu.
Halo, selamat siang. Apa suara saya bisa terdengar jelas?
Bisa, bisa.
Bisa, Dok.
Bisa.
Baik. Bisa saya mulai ya? Yeah, good morning, ladies and gentlemen, honorable speakers and colleagues and also students. Welcome to the second session of Stovit Online series. Thank you for joining us today's webinar. My name is Ayu and I will be your moderator for this session entitled Oral Cancer and Oral Potentially Malignant Disorder, Current Practice and Future Strategy. We will have question and answer session after the lecture. If you have any question, please type them in the Zoom chat box and then I will help you to read and answer with the speaker. First of all, let me introduce our honorable speaker today, Dr. Ajirafu Besat. Please the IT team to show the CV, the curriculum vitae for Dr. Ajirafu Besat.
Hello.
Okay, so Dr. Ajirafu Besat received a graduate diploma of clinical science in oral medicine in 1997 from Konkan University. Then he graduated as Master of Dental Science in Oral Pathology on 2002 from University of Sydney. And Dr. Ajirafu also graduated as a PhD in Dental Science from Hiroshima University on 2014. His current position as Associate Dean for Education in Faculty of Dentistry, Konkan University. Dr. Ajirafu teaching activities as a lecturer, clinical instructor, course director, and tutor for several undergraduate, residency, and also master program. He is also a member of academic committee of Thai National Dental Board Examination. And now his current research is focusing on establishment and characterization of primary oral cancers from OSCC patients in the northeast of Thailand. His publications are also numerous, including from a top-tier journal. So after this, we will give the opportunity to Dr. Ajirafu Besat to explain the lecture entitled Oral Cancer and Oral Potentially Malignant Disorder for Current Practice and Future Strategy. Dr. Ajirafu Besat, please. Thank you, IT team.
So good morning, everyone. My name is Ashiru Sumanpesat from Faculty of Dentistry, Konkan University. First of all, I would like to thank the organizing committee, especially Dr. Nurina Febrianti Ayuning Tias for inviting me to give a talk in this seminar, online seminar. And this is my probably second time to see all the familiar faces again, because I had an opportunity to visit everyone at the University of Airlangga in Surabaya, Indonesia 2 years ago. And so this morning, I would like to share my experience in oral cancer and oral potentially malignant disorders. So first of all, thank you very much for your kind introduction. But at Konkan University now, we have only master degree in oral diagnostic science, but we still wait to establish the residency program for oral pathology and oral medicine very soon. I hope that in not many years, we will be going to have the residency program for that entity, that specialty. So before starting my talk, so the oral cancer and oral potentially malignant disorder, before talking about cancer, so cancer is actually in our horoscope. We can see that cancer means crab, right? So Hippocrates was the first one to use the word cancer to describe tumors, and cancer is derived from the Greek word karkinos, which means crab. So it's thought that Hippocrates was referring to the appearance of tumors, and the main portion of the tumor being the crab's body, and the various extensions of the tumor appear as the legs and claws of the crabs. But there's also another hypothesis that Hippocrates might be able to see the surrounding of the tumor mass with lots of blood vessels, mimicking the crab's legs. So I'm not sure which one is the right hypothesis for the description of cancer by Hippocrates. But what is cancer anyway? Cancer is actually, from the American Cancer Society, they describe cancer as a group of diseases. The group of diseases characterized by the uncontrolled growth and spread of abnormal cells, and the spread is not controlled, and it can result in death. Before starting to talk about cancer, we need to mention about cancer stem cell as well, because these days cancer stem cells are defined as the cells containing in a tumor that can self-renew and drive tumorigenesis. So cancer stem cells, usually we, just only a few years back, we isolated the cancer stem cells from a number of human tumors, including hematopoietic, brain, colon, and breast cancers. The cancer stem cell concept is actually very important to cancer therapy these days, because if we can find whether we can target the cancer stem cell, we can probably cure the cancer itself. And then in the world, so we have two different parts of the world focusing on oral cancer. Actually, the diagnosis and survival of oral cancer in the US, they reported about 450,000 new cases per year. And then if you can do the early detection of oral cancer, so you can actually double a chance of survival to the patient from 40% to 90%. And the risk factors for oral cancer in the US, including tobacco use and alcohol use, and also exposure to HPV-16 virus. But usually if you drink and smoke at the same time, you will have 15 times greater chance to develop cancer. And probably in the US, people don't know much about oral cancer, even though the oral cancer can be very detrimental, and it can cause it can be a cause of death. But HPV-related oral cancer have been reported each year, about 30,000 new cases. And 65% of all cancers are linked to HPV. But fortunately, that HPV is not a predictive factor to sort of predict the clinical outcomes or predict the survival rate of the patient. Actually, if you can detect HPV in oral cancer, that means the survival rate is actually higher than the oral cancer without HPV. And then in the UK, they said the same thing about early detection of oral cancer, that if you can early detect the cancer, you actually can improve the survival outcome to 90%, especially if you can detect the lesion in the stage 1. And the common symptoms of oral cancer in the mouth, reported in the UK, they have ulcers, they have patches, and they have lumps in the mouth. And usually the risk factors are the same. So smoking, alcohol drinking, they include some poor diet as well. So usually in the UK, over 1,800 people died of mouth cancer in the UK alone. So the incidence of oral cancer worldwide, cancers of the lip and oral cavity, cancers of the lip and oral cavity are highly frequent in Southern Asia, especially in India and Sri Lanka, as well as in Pacific Islands in Papua New Guinea, with the highest incidence rate worldwide in both sexes. And it's actually the leading cause of oral death among men in India and in Sri Lanka. In 2018, the estimated new cases were about 354,864 cases. And half of them, probably, the number of deaths were about half of the new cases of oral cancer in the oral cavity, including lip cancer alone. So smoking, alcohol use, and smokeless tobacco use and HPV infection are the major risk factors for oral cavity cancer. And then smoking is estimated to account for about 71% of deaths from oral cavity cancer in high-income countries, and 37% of deaths in low-income countries. So actually, smoking is prone to be prevalent in the high-income countries, especially who can afford to smoke a lot. They will increase more chance to develop cancer. And then about 133 smokeless tobacco products and betel quid are the major risk factors in oral cancer in Taiwan, because in Taiwan, in India, and some neighboring countries, the smokeless tobacco are very popular. And then in the past few years, oral cavity cancers have decreased significantly, both in males and females in Asia, in Northern America, and also in Australia, and also among males in Southern and Western Europe. But the rates increased both in males and females in several countries in the Eastern and Northern Europe, especially in the Southern and Western Europe. It actually reflects the ongoing tobacco epidemic. So if we can reduce the use of tobacco smoking, so I think we can prevent the oral cancer in the long run. However, incidence rates for oral cancer sites related to HPV infections, especially in the oral pharynx, tonsils, and base of tongue, are increasing in some countries. So they hypothesize that it may be the change in oral sexual behavior. In GloboCan 2018, they reported the mortality rate in males, lip and oral cavity cancer. It's ranked number 10, but in female, it's ranked in the top 20. And especially in male, the lip and oral cavity cancer is number 10. But because in Southeast Asia, the prevalence of lip and oral cancers, it's like in the middle half of the whole world. So the highest prevalence of lip and oral cancer is in Melanesia and also in Papua New Guinea. What about in Thailand? We have National Cancer Institute of Thailand, and they usually research about the cancer prevalence, and also they usually create the cancer registry in every 5 years. In 2015, lip and oral cavity cancer was ranked number 6 in the leading site of cancers in the whole body. And the newly detected cancer in male, it's ranked number 5, and in female, lip and oral cavity cancer was ranked number 8. The newly diagnosed cancer in the first 15 ranks, the oral cavity cancer and also the lip cancer was ranked number 6. 95% of patients are over 40 years of age. And patients with stage 4 were found in the highest percentage, is about 50%, about 46.02% of the new cases of lip and oral cavity cancer. That means the 5-year survival rate, it depends on the stage of cancer, the type of cancer, and the site of cancer. So if you can detect it in the stage 1, the survival rate is 90%. But if you can detect the oral cancer in stage 3, the survival rate is only 40%. So early detection with adequate treatment can reduce oral cancer death and morbidity, and especially can reduce cost of treatment quite dramatically. Most oral potentially malignant disorders should be detectable at the time of a comprehensive oral examination. Because if you talk about oral cancers, the oral cancers are it's part of a group of cancers commonly referred to as head and neck cancers. And then oral cancers comprise about 85% of this category. And the death rate associated with this cancer is particularly high because it's hard, because the cancer being routinely discovered late in the development of cancer. So that means we need to early detect the cancer as much as possible and as soon as possible. So in 2018, Douglas Hanahan and Robert Weinberg, so both of them, they are the leading researchers in terms of cancer in the world. So they described the hallmarks of cancer in 2018, including that the cancer should have the tissue invasion and metastasis potential. So the cancer can spread to so many parts of the body and also can invade to the deeper part of the tissue. And it should be able to enable the replicative immortality by stop the function of p53 gene. And also it should evade the anti-growth signals. Moreover, if the cancer cells can avoid immune destruction, it can also be able to proliferate more. And if cancer can cause the genetic instability or can induce the new blood flow, so the cancer will last longer in our body and also in the oral cavity. Last but not least, if the cancer cells can deregulate the cellular metabolism and can resist the programmed cell death, the cancer cells tend to have lower prognosis. And especially in the area in the mouth, if the inflammation occurs, if the tumor can promote inflammation in the area where the tumor resides, it can lengthen the time to proliferate of the cancer cells. So the risk factors of oral cancer includes tobacco smoking, smokeless tobacco, alcohol consumption, HPV and EBV infection, poor oral hygiene, betel nut chewing, and also chronic irritation. So as you know that tobacco smoking has long been recognized as the most potent risk factor for oral cancer. So different types of cigarette smoking or tobacco smoking can be seen in many reports. The lower left figure is a handmade cigarette in the northern part of Thailand. They actually roll the tobacco with the dry banana leaf. It's called buri kiyo. And then the right side is from the Scandinavia. So usually it's called snus. They put the smokeless tobacco in the membrane. So you can put it in the mouth and it can live there for a very long time. Alcohol consumption, no matter the recipe or the formula of the alcohol production is, it can be the risk factor for oral cancer. HPV virus is actually one of the most well-known cause of oral cancer, but lately we found that HPV 16 can start the oral cancer, but it can affect the prognosis. Actually, it can make the prognosis better if you can detect the HPV virus within the cancer tissue. Usually, the HPV infection can cause the papilloma lesions like squamous papilloma or verrucarcinoma. EBV as well. It can cause so many kinds of infections in the mouth, including Haeberry leukoplakia on the left side and the infectious mononucleosis on the right side. EBV infection is related to several malignancies, especially the hematopoietic malignancies like Burkitt's lymphoma and also nasopharyngeal carcinoma. Poor oral hygiene is also reported as the cause of oral cancer, especially in the bedridden patients and also the patients with poor oral hygiene. Some bedridden patients, if the caregiver cannot give enough oral hygiene care, so they can develop some kind of oromyiasis, which is the fly worm in the area, because the patient when they sleep in the house and they open the mouth wide, the fly can lay eggs on the tissue and it results in numerous worms in the body, especially in the oral cavity. Betel nut chewing is very popular in Southeast Asia, but it has long been known as one of the major causes of oral cancer, especially when you have to use the tobacco leaves, the shredded tobacco leaves, to clean the stickiness of the betel nut on the teeth. Chronic irritation is also another cause of oral cancer. If there is any kind of chronic irritation in the oral cavity, you need to get rid of it as soon as possible. So at Khon Kaen University, we have oral pathology laboratory. In 10 years, we have about 10,000 cases, and it's outpatient for half outpatient and half inpatient. And oral cancers accounts for about 11.3% of all the cases. And the range of age, usually it's about more than 60 years of age. The highest incidence is in the mid 60s. And at our center, we found that female is more prevalent than male. The youngest age for oral cancer is 11 in our report, and 98 is the oldest age for oral cancer in our report. And oral cancer, especially squamous cell carcinoma, accounts for 34% of the oral lesions detected in the elderly. If you see the oral cavity, we have so many different sizes which can develop oral cancer. Like on the lip, if the lip exposed to sunlight for a very long time, like if you are a farmer in a farm and you don't cover your face very well, you can develop cancer in the lower lip very easily. The buccal mucosa, you can also detect some nodular pattern of oral cancer and with some yellowish plaque on top. And on the gingiva, actually the oral cancer imitates very poor periodontitis. It can induce the mobility of the teeth in the affected area. In the floor of mouth, it can cause swelling, and sometimes it can cause numbness. And on the tongue, usually the lateral side of the tongue, on both sides, they are very prevalent for, they are the most prevalent sites for oral cancer because they tend to be traumatized by the stroke of chewing, or sometimes at the back, especially in the posterior tongue, it's really hard to detect. So the hard palate, usually the oral cancer can occur as the ulcerated lesion, and you have to be able to differentiate from some kind of infection like herpes zoster infection on the left figure. And on the soft palate, usually you can get some kind of infection like herpangina, which can caused by Coxsackie virus. But then with the soft palate oral cancer, it usually turns out to be very ulcerative lesion. For oral potentially malignant disorder, there are conditions that precede the onset of invasive cancers of the oral cavity. And this term embraces the precancerous lesions and conditions referred to the earlier WHO definitions. And leukoplakia is the most common oral potentially malignant disorders. So actually they have something in common between oral cancer and oral potentially malignant disorder. I will select only some of them to talk about today. Actually, there are four quite unique oral potentially malignant disorders, including proliferative verrucous leukoplakia, the oral submucous fibrosis, and some erosive lichen planus and chronic hyperplastic candidiasis. The proliferative verrucous leukoplakia can occur in many parts of the oral cavity as the proliferative white plaque, which cannot be scraped off in a very low risk patients, like in the old female patients who never smoke, never drink, like that. But oral submucous fibrosis, it tends to occur in patients who chew tobacco, who use betel nut chewing, and also who chew the tobacco, the chewing tobacco as well. So the oral submucous fibrosis, unfortunately in Thailand, the prevalence of oral submucous fibrosis is not that high compared to in Taiwan or in the southern part of China, where it can occur in a very young age. Especially if you start chewing the betel quid very soon, you will develop oral submucous fibrosis very soon as well. The erosive lichen planus, actually you are very familiar with lichen planus. So erosive type of lichen planus is the type that we need to be concerned about because they can develop into oral cancer later on. So for erosive lichen planus, you have to do multiple site biopsy and you have to recall the patients quite often just to see the progress of the lesion. Chronic hyperplastic candidiasis is something that we learn about it for a very long time, but usually it can appear as the white shaggy lesion in the oral cavity in different sites, especially at the corner of the mouth. So chronic hyperplastic candidiasis, you have to do the biopsy to make a final diagnosis of it. So I would like to mention about lesions mimicking oral cancers in the mouth as well, because sometimes you can misdiagnose these lesions with oral cancer. The first one is oral tuberculosis. So usually oral tuberculosis can occur as the solitary ulcer, especially on the tongue and also on the palate. So this ulcer can lead to more investigations. So usually, if you see this kind of ulcer, you have to do the biopsy and to confirm the diagnosis, whether it's tuberculosis or not. On this slide, it shows the AFB or acid-fast bacilli positive slide showing the microorganism, the Mycobacterium tuberculosis in a very small and fine red spirochete. And also you can see the caseous necrosis, even though it's a small area with some Langerhans cell, which is very characteristic for oral tuberculosis. The fungal infections, both the mucormycosis and aspergillosis or histoplasmosis are considered as the lesions which mimic the oral cancer in the oral cavity. So when you take the history, so if the patient has the uncontrolled diabetes, you have to ask them more about you have to look through the mouth very carefully, and sometimes you have to do the biopsy in the area as well. And this lesion is very popular these days. It's called traumatic ulcerative granuloma with stromal eosinophilia or TUCSI. By the look of it, it looks like cancer in the mouth, but then if you do the biopsy shows only granulation tissue formation and also with stromal eosinophilia, which means the eosinophil accumulation in this area. And this last one is necrotizing cyalometaplasia. It occurs after some kind of dental treatment like the local anesthetic injection on the palate, and it can cause ischemia of the minor salivary gland of the palate. And by the look of it in histopathology, it looks exactly like oral cancer. So with clinical appearance, oral cancer can occur as leukoplakia, like the white plaque which cannot be scraped off. Maybe the superficial part of this lesion can be smooth or can be rough, or it can present as speculeukoplakia, which means the mixed lesion between red and white, or sometimes it can occur as erythroleukoplakia, or only red lesions or nodular lesions can be seen. On the lip, it usually occurs as the ulcer, but the surrounding edge of the ulcer is quite rubbery. And this lesion on the left side of the tongue occurs as a very small ulcer. It looks not very sinister, but then after you take the X-ray, you can see that from the MRI, the cancer already invaded half of the tongue, And this patient had to sacrifice half of her tongue because of the late detection of this cancer. Verrucous carcinoma is another form which can be seen in the oral cavity, like a shaggy white plaque which cannot be scraped off. And if it's present as a frank carcinoma, you can actually see it directly inside the mouth, and you can make a diagnosis very easily. The grading system of the oral cancer, we usually use T&M staging depending on the size of the tumor and also the metastatic node detection. In pathology, we use the Bryan score, but usually before talking about the Bryan score, there are some terms that you need to know about dysplasia. Is the change in the epithelium, especially in the basal cell layer first, and after that, the abnormality of the epithelium will occur for the entire thickness, especially in the late part of the speculococlegia. You can see that the early invasion of the cancer already occurs. So this is the pathology of mild, moderate, and severe dysplasia. It depends on the involvement of the abnormality of the cells. If it's halfway, it's moderate. But if it includes the entire thickness of the epithelial layer, so it can be called as severe dysplasia or carcinoma in situ. So Magna Bryan, he actually invented this histological malignancy grading by using the degree of keratinization, nuclear polymorphism, and also pattern of invasion and host response. So if the cancer invades in a very small nest, the prognosis is low. And also if you can detect keratinization, which can appear as white plaque, so the prognosis is good. Nuclear polymorphism, if you can detect nuclear polymorphism, high rate of nuclear polymorphism, the prognosis is poor. And the pattern of invasion depends on the size of the tumor. If the size of the tumor is big, the prognosis is better than the small size of the tumor islands. And also the host response, if our body can detect the invasion of the cancer islands, and you can detect a lot of chronic inflammatory response, that means the cancer cannot invade deep down to the underlying connective tissue or underlying structure very easily. This is the dot-shaped radial ridges, and this is the lymph node metastasis. You can see that when you detect by T&M staging, the lymph node metastasis is very, very important. So therefore, you need to check the lymph node on the neck all the time when you do the extraoral and intraoral examination. So usually for the treatment, they use neck dissection. They divide the neck into several levels. Normally for the surgery, they use only 5 levels. And then you have to be sure that the node metastasis is actually palpable, because sometimes with people with very thick neck, it's very hard to detect the palpable lymph node. Because sometimes when the lymph node is enlarged, that means like the lymph node itself, it can have some kind of cystic degeneration inside. And also in the cellular structure, if you have prominent nucleoli or abnormal mitosis, that means the prognosis of this cancer is very poor. So I'm going to talk about the screening just a little bit, just to make sure that everyone, I just want to emphasize the importance of the screening system. We have the detecting oral cancer. It's a guideline of detecting oral cancer from NIH. So usually the 5-year survival rate of localized disease of oral cancer is about 76%. And the tissue changes in the mouth, it can be the signal of cancer. So the warning sign is a lump or white plaque or some kind of difficulty chewing or swallowing. And numbness is also one of the warning signs. So you have to have the proper lighting, and also you need 5 minutes to detect some abnormalities. First of all, with extraoral examination, you have to palpate the cervical lymph node, especially the submandibular lymph node, which is prone to be detected if the metastatic cancer from the mouth occurs. And then you have to do the thorough examination of the tissue, starting from the lip and the labial mucosa, by both upper and lower, and bilateral buccal mucosa, gingiva, and also the tongue, and the lateral side of the tongue, which is prone to have early lesion of oral cancer if this area has been repeatedly traumatized. And then the ventral surface of tongue and the floor of mouth. Both of them are very important if the patients are tobacco chewer. And this is the hard palate and also the oropharynx. Especially in the anterior part of the mouth, the swelling of the anterior part of the mouth can be the early sign if there's some kind of ulcer in the floor of mouth as well. So the horseshoe-shaped area is the area where it's very prone to detect oral cancer. So this is the chronic ulcer with indurated border. This is frank carcinoma by the look of it. And then you can have necrotic ulcer with raw border, or some kind of mass with very irregular surface with granulated surface like this. Or sometimes you can detect some nodular lesion on the back at the back of the tongue, especially in the area where lingual tonsil is. You can have crusted ulcerated nodule and also ulcerated mass, which can disfigure your lip. Or sometimes you can detect just only white patch with granular surface, or red patch, which is more sinister. And sometimes you can detect it as a speculeucoplakia, or granular and red and white lesion, or diffuse red and white lesion on the tongue. Sometimes it mimics erosive lichen planus. That's why the importance of the biopsy should be emphasized. So the screening technique, we usually, apart from the thorough examination of the oral cavity, we can use some kind of adjunctive technique like toluidine blue or Lugol's iodine. So with toluidine blue or toluidine chloride, it's very basic. And when you stand on the suspected area, these plastic tissues appear as blue color. But unfortunately, the limitation of this staining, it can also cause false positive in the ulcerated area. So you need to be sure that you apply this toluidine blue on white lesion or speculeucoplakia. And then you have to apply the toluidine blue first. After that, you rinse your mouth, and then you just wash away. After you wash away the excess toluidine blue with water, you have to decolorize the area with 1% acetic acid. The sensitivity is high, but the specificity is not very high. Glucose iodine, the dysplastic tissue will appear as pale. So the sensitivity is also high, but specificity is higher than toluidine blue. So you can use this, but unfortunately, the glucose iodine is not very commonly used in Thailand. And then some researchers, they also use something that you can find in the kitchen, like vinegar. So the acetic acid, it has like 87% sensitivity, about 86% specificity. It can tell you something, but the biopsy should, where the biopsy should be done, but the specificity and the sensitivity is still in consideration. In the Western world, they use oral CDX, which is more complicated and technically sensitive. For you need to roll the area, you need to move the brush and to remove some part of tissue and spread it on the slide and send it to the lab. But in Thailand, it's not very popular because it costs some money and the patient cannot afford that. Fine needle aspiration can be done if the palpable node is detected or some kind of swelling occurs in the area that we can approach, like on the soft palate. Anyhow, the fine needle aspiration needs some skill, so the operator should be skillful enough to obtain enough material for examination. So right now, we're going to use the Bell scope as the screening tool for oral cancer, because this kind of technique has been used for quite a long time in several countries, but the results are still controversial. But anyway, if you can afford the Bell scope can show you the area that should be biopsied. So the area where it absorbs the light the most, it is the area where you should biopsy the most. And then the biopsy should be done. The technique of the biopsy includes the excisional biopsy, but usually for oral cancer, we use the incisional biopsy to get the initial diagnosis to confirm whether it's cancer or not. In the novice or amateur practitioner, you can also use punch biopsy because it's easier, but it's also technically sensitive when you want to retrieve the epithelial part, because it can remove the upper part of the epithelium very easily. And then you also can use the staining method to differentiate between the cancer area and also the normal tissue. Like in this one, you can see that the upper figure, you cannot detect where the tumor islands are, but then after you stain the tissue with cytokeratin, you can detect the spindle cell carcinoma invading into the underlying connective tissue. So, squamous cell carcinoma in soft tissue, usually we know that it's the most common oral malignancy and it originates from the epithelium. But then in clinical features, usually it occurs in male more than female, and it's more than 50 years of age. But what I would like to address here is the look of it on the radiograph. So usually if the squamous cell carcinoma occur on the gingiva or lateral border of tongue involving the floor of mouth, the bone invasion can also occur in the lingual aspect of the mandible. So you can see that these three figures, they show the early sign of oral cancer invasion. So you can detect that the cancer mass, the tumor mass, it's is a soft tissue mass that you can detect on the X-ray. But oral cancer itself can only cause the saucerization. In some cases, they can cause only saucerization, which can mimic the periodontitis. But sometimes you can detect the irregular border of the area where the tumor mass is situated. So for X-ray of oral cancer, you have to check whether the edge of the area, the radiolucent area, is irregular or not. Usually it can occur in the area where you have a long-standing lesion, especially the soft tissue overgrowth, especially in the posterior part of the mandible. And sometimes the detection can be very useful by X-ray if the tumor mass is large enough to erode the cortex of the mandible. So usually, if the squamous cell carcinoma can occur surrounding the area where the teeth are, so the widening PDL space can be one of the prominent features on the X-ray, and also loss of lamina dura. Some large tumor mass can float the teeth, and also it can destroy the cortical border. So differential diagnosis of squamous cell carcinoma in soft tissue, when it appears on the X-ray, you have to differentiate from osteomyelitis and periodontitis. Therefore, the squamous cell carcinoma in the early stage cannot be easily differentiated from the periodontitis or even the inflammation of the bone itself. Last but not least, I would like to mention that oral cancer treatment, we have so many side effects after or complications after the treatment of oral cancer has been started. So this patient, he actually had his cancer removed from the left mandible. And then he had the radiation therapy. But later on, he came back with a very black slough and smelly slough, like necrotic area in the mouth. On the X-ray, you can see that the area of the bone turned to be abnormal. I mean, like you can observe the formation of the bony mass inside the area of the left mandible. The bony mass here, it imitates the osteomyelitis, so it looks like the moth-eaten. But then the biopsy was done in this area because of the bone overgrowth. So we can detect the abnormality of the bone cells in this area, including some malignant mesenchymal cell, which is the cause of this lesion. So this lesion is interpreted as radiation-induced osteogenic sarcoma. This is another patient with the history of a mucoepidermoid carcinoma removed from the left area of the mouth. So after a while, he developed some kind of swelling in the masseter. So the biopsy was done from the area. Because the mucoepidermoid carcinoma itself, the surgeon could not remove the whole tumor. So there are some area of the remnant of the tumor on the backside of the surgery. So the surgeon decided to send the patient to the radiation therapy. But then he developed this tumor causing the overgrowth of abnormal bone. So the diagnosis of this case is also radiation-induced extraskeletal osteogenic sarcoma. So that means even though we try to solve the problems by sending the patients to have the surgery done, and after that we try to prevent the recurrence by sending the patient to radiation therapist. But unfortunately, some patients can react to the treatment by forming another tumor inside the area where the previous tumors are situated. So this is like a warning sign that the treatment of cancer is the double-edged sword. So it's the you have to be sure that after the treatment, you recall the patients and you observe the mouth very carefully for some kind of alteration or some changes in the mouth to detect whether he can develop some kind of tumor after the treatment or not. So for my presentation, I think I would like to conclude this presentation that usually sometimes when we can detect the oral cancer in the mouth, people say like, this is the worst thing that can happen to someone, like shit happens, so get over it. I mean, people should move on after the diagnosis. People tend to avoid the treatment as long as possible. So as the dental practitioner or the specialist, we need to educate the patients to not be afraid of the treatment, because otherwise, if they avoid the treatment for too long, the prognosis will be worse, and then we cannot cure the cancer. And then for the dental practitioner or the specialist, we have to keep calm and carry on our duty. First of all, as the specialist for oral cavity, we need to be able to recognize the lesions inside the mouth. And also we need to be able to send the patient to the specialist if it's out of our hand. I mean, like if we cannot do the biopsy or our facility is not well equipped enough. And then we do hope that for early detection of cancer, we can reduce the risk of mortality in cancer patients by half. And we actually hope as well to be able to develop some kind of early detection system and the treatment which can affect the quality of life of the patient the least, because patient has to live with cancer in the mouth, and after that they have to live with the complications after the treatment as well. So as as we are dentists or we are the oral physicians, so-called, we need to we need to examine the mouth very carefully to detect the early sign of oral cancer, just to help the patient get the treatment and the diagnosis as soon as possible before it's too late. So thank you very much. I think this is it for my talk for this morning. So if someone would like to ask some questions related to this talk, please feel free to do so. Thank you very much.
Thank you very much, Dr. Ajirafut. Could you hear my voice clearly?
Yes.
Okay. So we arrived to the question and answer session. And looks like that we have several questions in the chat box. So I will start to ask about the first question.
Yes.
First question come from Dr. Kurnia. She asked about her patient. So she has patient with severe dysplasia based on the FNAP
Yes.
examination located in the lateral side of the tongue. And the patient also have thrombocytosis due to JAK2 gene mutation also detected in that patient. And she is wondering whether is there any relation or influence between thrombocytosis with development of oral cancer and about the prognosis. Okay, that is the first question, Dr. Aji.
I can hear the last part of the question very well. So the lesion occurs on the lateral side of the tongue, and it was diagnosed as severe dysplasia, right?
Yes.
And then
she is diagnosed only with severe dysplasia based on the FNAP examination. And she also have the thrombocytosis due to JAK2 gene mutation. And Dr. Kurnia was wondering, is there any relationship between thrombocytosis with the development of oral cancer?
Thrombocytosis?
Yep.
I think it, from my experience, I think it's not that related between the thrombocytosis and the severe dysplasia in the lateral side of the tongue. I think mostly the severe dysplasia on the lateral side of the tongue, usually it's provoked by chronic irritation or localized trauma. So I think the best way is just to see the surrounding area, whether it has some kind of predisposing factor or some kind of related factor which can cause the irritation in that area. And with the severe dysplasia, I would recommend the total removal of the area, especially on the lateral side of the tongue, because it's very prone to develop further to oral squamous cell carcinoma. So I think that's my answer for this question.
Thank you very much. So maybe the prognosis is good if we do the total excision for this patient.
Yes. Because usually in Thailand, we, especially with potentially malignant disorder, because for this talk, I didn't put so many oral potentially malignant disorders because they are quite related with the detection of oral cancer, because some of the lesions can be similar, like the leukoplakia or erythroplakia or spectroleukoplakia. But then the lateral side of the tongue at my school, it's also the second most prevalent site for oral cancer. Unfortunately, the most prevalent site of oral cancer in the northeast of Thailand is gingiva. So I think as a dentist, when we look at it, both in the mouth, we have to check the gingiva very carefully and also the lateral side of the tongue very carefully. Severe dysplasia cannot be left like that. Normally in Thailand, if we do the biopsy, a small biopsy shows some severe dysplasia, we need to send it to the oral surgery for the total removal of the area. But before doing so, we need to do multiple site biopsy to make sure that there is no invasive carcinoma inside the area where the severe dysplasia was diagnosed firsthand.
Okay, thank you very much. Yeah. So I think it's already clear that severe dysplasia is has the irreversible characteristic, so that we need to do total excision. And next question came from Dr. Lani and Dr. Niputuriskayanti. They asked about the predilection factor of oral cancer. Is there connection between heredity and also a gender as the predisposing factor for oral cancer, whether it can be a standalone factor or a cofactor.
Okay, so it's very strange. This question can be very hard to answer because from the Global Can 2018, so usually the lip and oral cavity cancer was ranked number 10 for the total cancer in the total body. But then in Thailand and in the South, I think in Southeast Asia as well, we tend to think that male should be prone to have cancer than female. But I don't know why. In the past 10 years, I think there are increasing numbers of female patients who develop the oral cavity cancer with and without predisposing factors. So this is very, I think it still needs some kind of investigations and also the collection of data, because I'm not sure whether it's because of the behavior or it's because of the prevalence in each region, which can cause the difference in this data. For the gender, I think at first I thought that female should be more scrutinized. Especially when you look into the mouth, you will be more concerned. So you will go to the doctor or to the dentist earlier than male. But then in the lab, I got so many cases, referral cases for oral cancer. Unfortunately, most of them, I think more than, as I showed you before, like more than half of them, they're female patients with and without risk factors. Some female patients, they are old, they tend to be old. So probably because female is more patient than male, is more sort of, they might not say anything unless the condition is very severe, I guess, in the region. So that's why the data of more oral cancer in female is increasing. I'm not sure whether this is the right answer for the question or not, but for me, with the gender, it contradicts with the overall data of the world. But in the Southeast Asia, I think female patients tend to increase in number.
Okay. So maybe we need to do a further experiment to clarify this clearly, right?
Yes.
And we move to the next question. So next question comes from Dr. Rizka. She asked about the a patient which already suspected with oral potentially malignant disorder. So usually if someone diagnosed with oral potentially malignant disorder, for control, we need to do control for how many months after she diagnosed and to do follow-up regularly, or maybe what kind of tests that should be done to do the follow-up.
Okay, for oral potentially malignant disorders, I would recommend, like if it's erosive lichen planus is a very long-standing erosive lichen planus, which is very recalcitrant. That means like it doesn't respond to the treatment very well. I think multiple site biopsy should be done to make sure that there's no malignant change in the area. But the rest, like the if it's leukoplakia, like if you cannot exclude any kind of any possibility of friction or some kind of local trauma, and you already solve the problem by like remove the cause, but it still exists or persists, I think it should be, the biopsy also should be done on the lesion. And then how long you should wait for some suspicious lesion like that. I would say that if it's very shaggy, like it's exophytic, but it's like white plaque with exophytic what is it called, superficial surface, it tends to be less aggressive compared to the very small but deep ulceration. So if you compare the lesion that you see in the clinic, but if it's a persistent ulcer and you remove all the cause, it still exists, I think that one is very, it needs to be examined very soon, because exophytic lesion tends to behave less aggressively, but then the ulceration or deep ulceration especially, or the very irregular ulcer on different sites in the mouth, it should be biopsy.
So maybe the such as the homogeneous leukoplakia, we need to do the follow-up regularly, maybe about 6 months, every 6 months, like that. Is that safe for the patient?
Usually, if it's related to the lesion that you can diagnose clinically, like if it looks like lichen planus with no ulceration, like a reticular pattern of lichen planus or plaque type lichen planus, I think you can observe it and you can treat the lesion for a while. But then if it's ulcerated, I think the biopsy should be done straight away, just to make sure that there's no area where the malignancy already occurs.
Okay, so maybe for the lesion that has characteristic high transformation to malignancy, like the a red lesion, such as erythroplakia, we need to do the biopsy as soon as possible.
Yes.
It's like that. The same with the ulceration, like a deep ulcer that you mentioned before.
Yes.
So
usually you have to remove all the causes first. You have to remove all the causes that might cause the ulcer or might cause the white area. So if you remove all the related factors, but they still persist, I think the best way is just to do the biopsy and see it under the microscope straight away.
Okay, so that also can answer the question from Miss Patricia De Losa, maybe from your students.
Yep.
She also asked about the erosive lichen planus, that how we can see the clinical side and changes that we need to consider to redo biopsy and check also if the lesion has turned to a malignant or not yet.
Yeah, so usually with the clinical signs and changes that we can observe in erosive lichen planus, that means like it doesn't reduce in size, even though we try to treat with different types of medications. So in Thailand, we use the very potent fluocinolone acetonide, and also there's some area. Usually we need to educate the patient to clean the mouth very well, because the inflammation, the local inflammation, can make the lesion persist more than we expect. It seems like if you cannot clean the mouth very well, the medication cannot be very effective. So first of all, you need to educate the patient to clean the mouth very well. And then after you observe whether if the oral cavity is very clean, but the erosive lichen planus after treatment is still persist and it doesn't reduce in size, I think second biopsy should be done. And I would recommend you take the photographs every visit to compare the progression of the erosive lichen planus. So you might change the area where you do the biopsy if you think the pattern of the erosive lichen planus has changed. So that's, I think that's the recommendation. So how often you need to do the biopsy, to redo the biopsy? I think less than 3 months, you need to redo the biopsy, in my opinion. I think 6 months is too long. I think 3 months is okay. If you ask the patient, you recall the patient regularly and you observe that the lesion doesn't respond to the treatment very well, I think you have to look at the lesion again and find the area you think it might be abnormal, and then you do the biopsy.
Okay.
especially at multiple sites.
It's clear, Dr. Aji.
Yeah.
And next question comes from Dr. Ari. She asked about is there any relationship between poor oral hygiene, and oral cancer progression?
Yes. So this is very important because poor oral hygiene can cause oral cancer, especially gingival cancer. So I would say that as we are mostly dental practitioners, so what we can do best is just to clean the mouth very well. So I think the local irritation or chronic inflammation, especially in the gingiva, can be a major risk factor for developing into the gingival squamous cell carcinoma. So as we can help the patient by cleaning the mouth thoroughly and carefully. I think we need to recall if you see some suspected area in the gingiva and you think that it's related to inflammation, you do the scaling root planing very carefully. You educate the patient about the oral hygiene instruction, and after that, you shouldn't let the patient go easily. You have to ask them to come back for recall, just to observe the area where you clean the air, where you already clean the area carefully, and compare. That's why I asked you to take the photograph in the suspected area every visit that you ask the patient to come back. So you can compare whether after the treatment, it's already better or it's still the same. If it's still the same, it's still irregular, very nodular, and it can cause some kind of tooth mobility, I think the biopsy should be done.
Thank you very much. And because we have many undergraduate students also join in the Zoom meeting, we would like to ask about the GP role, because GP are the first line for early detection of oral cancer. So is there any tips and tricks to avoid misdiagnosis of oral potentially malignant disorder?
Tips and tricks to avoid
undergraduate students.
Yes. So usually most prevalent lesions related to oral potentially malignant disorder, they have white plaque and ulceration in combination. I think most of them, they have white plaque and ulceration in combination. If you see some white plaque, even it's a linear white plaque or even like a very patchy white plaque with some ulceration, I think you have to observe that carefully. And if you're not sure, you have to send the patient to the specialist to do the biopsy. In my opinion, I'm afraid that the cytology, like the just this scraping the area by the look of it on the histopathology point of view, I think for the lesion, which is very ulcerative in nature, I think that's not enough. Like if you see the area where it's a white plaque and you don't know how to do the biopsy, and it consists of the area where some ulcer occur in the same area, I think this area should be biopsied. So
they also need to know about the normal variance of the,
that's right.
the oral mucosa, right?
So recognition of the lesions is very important. So if you're not sure whether this is the area, what is it called? The abnormality of the oral soft tissue or not, I think you might need to have some kind of the flip chart or something. In Thailand, we have we now developing like an application with several pictures of potentially malignant disorders and also the frank carcinoma, just to compare with the clinical picture. So you won't miss it if you examine the mouth carefully. I guess.
Thank you very much, Dr. Aji. Next question comes from Dr. Rosaline. She asked about the oral submucous fibrosis.
Yes.
She wants to know, is there any connection between the stage of difficulties in mouth opening in oral submucous fibrosis with the initiation time of the oral cancer?
I think to my knowledge, I think it's not very related. I mean, like the terms of the, I mean, like the limitation of mouth opening and the severity of the dysplastic change in the oral cavity. I just only to my opinion on this, I think they're not very related. I mean, because submucous fibrosis can occur in a very young age in some ethnic group, you know, like in China. I went to China 2 years ago, and I observed a lot of patients with submucous fibrosis. They tend to come from one area, like from the southern part of China or from Yunnan, this Yunnan region, and also some part of Taiwan. So I think the ethnic origin, I mean, like it's very important to the severity of oral submucous fibrosis. And even though the fibrosis is very thick and it limits the mouth opening, the oral carcinoma, it occurs in the epithelial part. So it's the overlying epithelium. The one thing that might be related is that if you cannot open the mouth widely, you cannot clean the mouth very well. And sometimes when you use the tobacco smoking, like when you chew the betel quid, you use the tobacco smoking, the smokeless tobacco as well. You put it in the mouth and you cannot open the mouth very wide. Sometimes you cannot remove the remnant or some bits of the tobacco, like these smokeless tobacco from the mouth, and it sits there for a very long time. So that's the only relationship that I can think of in terms of the limitation of mouth opening and the development of cancer. Apart from that, I think it depends on, it's like case by case basis, and also it depends on the ethnic group as well.
Okay, thank you very much. After that, we have last two questions because I'm afraid that we have limited time for the discussion session. The first comes from Dr. Felicia. She had two patients presented with the radiolucency in the periapex region. It resembling the periapical abscess that turned out to be OSCC. And she wants to know about how we can differentiate between the usual periapical abscess and OSCC.
Is there any, I mean, like I really want to know the connection of the radiolucency and the overlying bone. If there is no overlying bone at all, it looks like floating tooth like that. So it can be related to oral cancer, like especially gingival cancer. But then if it occurs only at the apical part, like it resembles radicular cyst, and if you do the biopsy and it turns out to be oral cancer, that must be some kind of cancer in from radicular cyst or pre-existing radicular cyst, which can occur. I mean, like carcinomatous change can occur in almost every kind of cyst. Especially the most prevalent one is radicular cyst and dentira cyst. There are some cases where patients came with wobbly tooth, and then we remove the tooth, and they have like a small area of radicular cyst-like lesion in the anterior maxilla. But after we examine the tissue, it turned out to be squamous cell carcinoma as well. But we could detect the area where the radicular cyst is like a dysplastic change or malignant change within the radicular cyst epithelial lining. So it depends. I think if it occurs as very large radiolucency involving the periapical area and also the the crestal bone, I think that may be a part of gingival squamous cell carcinoma. But if it's localized only in the apical area of the tooth, I think that may be the carcinoma does change of the pre-existing radicular cyst. It's rare, but it can occur. Yep.
Yeah. Okay. Thank you very much, Dr. Aji. And the last question comes from Dr. Maswa. She asked about the passive smoker. So, is there any correlation between a passive smoker and oral cancer progression? Because as we know that also in Indonesia we have many smoker, and automatically that there are many people that become the second-hand smoker or passive smoker. So, is there any relation between them?
This is very hard to answer question because I think because the limitation of the data, we cannot say this now that this second-hand smoker can develop the oral cancer, because usually the oral cancer it needs the local factor quite a lot. So I feel that the second-hand smoker can get the lung cancer very easily. There are so many cases of lung cancer from the passive smokers, like the husband smokes a lot, but the wife doesn't smoke but live in the same room, so they can develop lung cancer. Like I didn't show you, maybe I show you from the first slide from the Global Can 2018. Nowadays in the Southeast Asia, lung cancer is highly prevalent in female patients. So I think half of them may be from the second-hand smoker. But then with oral cancer alone, I still cannot conclude that it's relevant. But I think we need more data to investigate the correlation between the second-hand smoker and also the oral cancer. But oral cancer itself, if you smoke directly, it has the toxicity. I mean, like some toxins can live in the mouth very long time. We need local factor to start the dysplastic and malignant change in the oral epithelial cells. That's why I think until now I cannot say it's related, but maybe we need more data.
Thank you very much, Dr. Aji. So I'm afraid that we arrive in the end of the question and answer session.
Yep.
And I hope that we have covered all of the questions. We appreciate for all participants being here and joining our webinar today. Thank you very much and good afternoon, everyone. And for Dr. Aji Rafut and his students, Miss Patricia and also Mr. Kurt, would you mind please still join the Zoom meeting for taking picture together with our staff and resident of Oral Medicine Department, Faculty of Dentistry?
Okay.
Yeah, could you please wait for a while? Thank you very much.
Thank you. Thank you very much, everyone.
Thank you, Dr. Aji. So nice to meet you again.
Hello, how are you? I haven't seen you for a while.
A year, exactly a year ago.
Year, that's right. Almost a year. Oh, already a year ago.
Already a year, yes.
December last year.
Yeah. Today, I don't know what's wrong with me. I'm stuttering all the time. I'm so sorry. I just feel myself like I'm being myself now. But before that, maybe I'm just too nervous about so many technical problems occurring to me. So many days before.
This technical IT and everything gives nerves, actually, really.
And the questions are very, I mean, like very thought-provoking, and some questions are very hard to answer because I think it depends on so many. I think each region and also each country has its own characteristics in terms of behavior and also the consumption of
right. And the questions came from most of our oral medicine residents, actually. They come from many parts of
of
Indonesia.
Indonesia, I
Yes.
remember.
You're going to meet them after this. We're going to move you to a breakout room where we're going to take pictures, and you can meet our.
I'm sorry. Maybe we will stay in this.
Oh, you stay here?
Then, because the next session will start from 1 p.m. So the other participant will leave, and then we will wait here for a while.
Ah, okay.
For taking picture together.
Okay.
Okay.
Tell them then. Jadi mahasiswa yang lain yang ini bisa leave Zoom dulu ya. Atau dibantu sama hostnya untuk nge-kick.
Berlangsung, berkurang.
Let the host kick the other participants so that we have the room for ourselves.
Dr. Ajirafut, so your students came from a residency program or master program?
Actually, at Konkan University now we have 2 residency programs. One in oromaxillofacial surgery. The other one is in orofacial pain and occlusion. So these, one of them, I mean, Miss Patricia, she's a resident in orofacial pain and occlusion, but usually she has to work in oral medicine clinic. She has to do some biopsies as well. But Mr. Kurt, he's actually in my master degree program in oral diagnostic science, and he works in the oral medicine clinic quite often, and now he also works in the oral pathology lab as well.
Yeah, I see.
So
and we also have a distinguished guest today, all the way from Tokyo. Saka, how are you?
Hi, hi.
Saka, how are you?
Hi,
She's in
fine.
Tokyo
I have
now.
Quarantine time in Tokyo until 21st of November.
Oh, okay. You're still being quarantined in Tokyo.
Yes.
How is everything? It's okay?
Yeah, it's okay. It's very cold in here.
Yeah, I can imagine how cold it is.
Yeah, it's November, almost December.
Even in Thailand now, it's very cold.
Even in Thailand, yeah. Yeah, you're in northern Thailand. Yeah, that's why it's very cold there. I watch NHK every day, Saka.
Oh yeah, really?
Yeah, to feel your atmosphere.
Yep.
The number of cases in Tokyo rises low.
Yes.
Be careful out there.
So worrying.
What about in Thailand, Dr. Aji?
You mean the weather or
the number of COVID cases?
Not quite. I think because now like we wear masks all the time, so I still think that this new habit makes us stronger. It's like we don't catch cold very easily now.
Okay. So people are very strict in wearing masks and wash their hands, everything.
Yeah, I think these days. I think maybe because
even the I mean people like people in the market or the like ordinary people.
Some
are they strict
stores,
also?
I mean, like some department stores, they prohibit people with no mask.
Yeah.
Okay. So that means like you have to get one mask before entering the building.
Yeah. We also have that rules here for the big department stores, for the shopping malls, and etc. But in the market, I mean the ordinary market, the traditional market, you cannot make people do that. I mean, there are still so many people going around everywhere without masks, or they only wear their mask like under their nose like this. Yeah.
Dr. Ajiraput, maybe one of your students, Dr. Patricia, already leave the meeting, or because I cannot see her again in the participants view. Yeah, only Dr. Kurt.
Yeah.
Can you invite her back? Can you invite Dr. Patricia back?
Can you please take picture together?
And maybe ask her a little. We got Dr. Kurt here, Dr. Florentino Kurt. His video is still off, by the way.
I call her.
Ya, okay, thank you very much. Ini 2020 sudah masuk ya? Kayak
2020 ada nih, ada Rosi.
Ada.
Ini siapa nih? Nadia Melinda sama Dr.
Yeni.
Tri Yuliani.
Yeni ada.
Yeni ada kok.
Iya.
Nadia Melinda siapa ya?
Oh ya ini ada, oke. Sebentar.
Pasti belum ngeluarin video. Terus Yuhana nggak ada?
Tadi ada deh kayaknya Johanna.
Oke. Mickey Mouse-nya ya, aduh nggak muati. Kalau ikut webinar itu mbok ya pakai blues gitu loh. Iya, belum juga masuk udah dimarahin sama KPS gimana nih? Itu di mute Yuhana nggak kedengaran.
Tadi habis dari kantor dong, habis lepas baju jaga.
Oh, ini from Dr. Kurt. Dr. Florentina has problem with the connection, but she's trying to reconnect already. Okay, let's wait for her. Dr. Kurt, can you turn on your video, please? We would like to meet you. Hello. Hello, my name is Dr. Daisy.
Florentino.
I'm Dr. Daisy. I'm the study program coordinator for the oral medicine specialist program, residency program in Universitas Erlangga. So Dr. Kurt, Dr. Aji said that he is from the master of the oral diagnostic, right? And how, is it a 2-year program or 3-year program?
Mute.
Yeah. Actually, it's 2 years program.
2 years program. And what year are you already?
He about to start the 2nd year.
Oh, I see.
Yep.
Okay. Well, what is his research topic about?
Ask him.
Dr. Kurt, please answer.
Starting with determining the salivary components of patients with burning mouth syndrome.
Burning mouth syndrome. Okay, you have lots of cases of burning mouth syndrome there in Konkan University Hospital?
Yes, quite a lot. Because we have a very big center of orofacial pain. That's why actually it's a combination between orofacial pain and oral medicine, because burning mouth syndrome can be treated in this facility, and also we can help the patient with xerostomy by providing some. Now we're trying to invent some artificial saliva specifically for the xerostomic patients. So actually his research can be done in the clinic. It's mostly clinical research, right, Kurt? So we going to use to collect the saliva and also to analyze the components of the saliva in burning mouth syndrome. And also his advisor will also introduce kind of artificial saliva like in the making. Now it's in the making of artificial saliva to be used in the clinic as well.
I see. So I think because you said that Dr. Patricia is from the oral facial pain residency, then Dr. Kurt and Dr. Patricia must be working together a lot.
Yes.
Interesting. We also have a research going on here for artificial saliva. Dr. Yasmin, right? Your research right now about the artificial saliva using the olive oil extract, right?
Yes. Hello, Dr. Aji.
Hello.
Why don't you share about your research?
But I think it's pending because of pandemic, Dr. Daisy.
Too bad. Many lab works are postponed here because of the pandemic.
Yes.
We have the same
Okay.
problem with the clinical research, and also to like invite all the subjects to come to the facility, because the government stopped all the activity for many months, and then we started to reopen the school just 3 months ago, I think. But then
all the activities has been restored normally, or
yeah,
it's still combined between the online and the normal?
Not anymore, because these online sessions, I think they were done already. Now, because in dentistry, we need to practice quite a lot to get the requirement for the national board exam. That's why this time we have to use the social distancing strategy and ask the patient, ask the students to bring the patients in the clinic, but not in a large number. We have to limit the number of the patients each session. And also now the faculty has invested a lot of money on the improvement of the ventilation. So that means like in the very near future, I think that the overall process will be finished by next June.
Okay. So the university hospital has been undergoing a lot of renovation right now to accommodate
quite a lot of renovation, including the oral medicine and orofacial pain clinic as well, where Kurt and also Tricia are now working.
So you all have to work with the PPE level 3 every day now.
Because we consider the oral medicine and orofacial pain as non-aerosol
producing.
That's right. So we don't need to wear the PPE that much. If you need some kind of scaling, replaning, or the tooth filling, we need to move it to the facility, and also we need to wear PPE.
Yeah. So you have you divide the section for the aerosol producing activities and the non-aerosol producing activities, right?
That's right.
Yeah, that's what we're trying to do all here.
Since we are already joining this Zoom meeting, could please take picture first?
Yeah, please.
Rere atau Mas Adistian, ini cukupkah 27 partisipan?
Yang ngambil foto saya atau dokter sendiri?
Dokter Merkurius cukupkah 27?
Iya, itu saja mungkin.
Nggak cukup, ini hanya ada 25 di dalam satu screen.
Kalau Rere, view-nya bisa berapa galeri view-nya, Rere?
Sama 25 juga ini.
Sama 25 juga ya.
25. Jadi kita mengambil dua scene nantinya.
Ya udah, oke. Ya udah, gitu Dokter Merkurius saja, Rere. Terima kasih. Tolong ya, so we will take picture together. Please count, Dr. Merkurius.
Pindahin aja, tuh admin SOS-nya pindahin ke belakang.
Oh pas kita di sini. Admin
ya,
SOS.
Kalau admin SOS-nya dibuang ke belakang kan jadinya kan bisa kan.
Oke, semuanya ready. 1, 2, 3. Oke, once more. 1, 2, 3. Okay,
thank you.
Dr. Aji, one more question. Dr. Aji, one more question. Yeah. Have you treated any oral manifestations from the COVID disease for patients in the university hospital?
No, but we just had the online discussion just on Wednesday about the oral lesions associated with COVID-19 infection. But mostly we observe some, not here, but then in the country, some centers, they observe the patients with COVID-19 and oral lesions as well. And probably in the northern part of Thailand.
I see. But there is but in your university hospital, do you treat the COVID-19 patients or do you refer them?
Actually, if it's like very highly infectious state, we normally send the patient to the main hospital. We don't treat the COVID-19 positive
Okay,
patients
so
ourselves. So usually
our dental
we
hospital,
do
yeah.
the quarantine and we just try to what is it called? Restrict the number of procedures that we can do.
Yeah. Yeah, because every patient who come to our dental hospital is also screened for COVID-19 using the rapid test.
Yeah.
And if it turned reactive, then we refer them to our main hospital, the main university hospital, and we don't treat the oral conditions at all. They have to focus on the COVID positive first.
Yeah.
Okay, Dr. Ayu, it's so sad that we have to say goodbye again to Dr. Aji. Hopefully we can have more sessions like this.
For the nice lecture.
Stay safe, Dr. Aji. Stay healthy.
Sure.
Thank you very much, Prof.
Yeah, stay
Savitri.
safe, everyone. Stay
Thank
healthy.
you so much.
Yeah, thank you so much, Dr. Kurt and Dr. Patricia, also to join this session. Hope to meet you again, and maybe we can do future sessions like case reports, or you can show your cases that you treat there, the orofacial pain cases, and also we can also share the cases that our residents here treat. And Dr. Saka from Tokyo and Dr. Rizka. Dr. Rizka doesn't join, yeah. Maybe next time she can join, both from Sendai. Saka and Rizka from Sendai can also join. That's the beauty of this online meeting, because everyone can join. Okay, thank you very much. Thank you very much. Goodbye. Stay safe, stay healthy. Goodbye.
Bye.
Thank you. Bye.